Welcome back to our series on evidence-based practice. In this fourth episode, we'll be diving into the culture of healthcare and we'll explore what it means to work in healthcare day to day. We'll look at job expectations, how care is organized in different practice settings, and the vital role of privacy laws. We'll also examine professional and ethical issues that health workers regularly face in workplace. By the end of this session, you should have a clearer picture of how evidence based practice is influenced by the culture and structure of healthcare environments. Objectives for evidence based practice in clinical engineering. And today's objective is to describe how EDM can be applied to key clinical questions of diagnosis, harm, and prognosis. So, for diagnosis, just to expand on the clinical engineering side, engineers evaluate whether diagnostic technologies like ultrasound, MRI, or AI driven software deliver accurate and reproducible results. Harm, engineers assess device related risks such as alarm fatigue, radiation exposure, or software failures, or even recalls on unauthorized use materials for design of medical devices. Prognosis, engineers help determine how technology influences long term outcomes, whether advanced monitoring systems improve recovery rates or quality of life. So let's go ahead and get started. Diagnosis and diagnostic tests. So we're focusing on diagnosis and in particular how we can use evidence-based medicine to assess questions about diagnosis. The diagnostic process combines two powerful tools: logical reasoning, which is using symptoms such as frequency, duration, and severity to rule conditions in or out, and pattern recognition, so matching the constellation of symptoms to the typical presentation of known diseases. And together, these approaches help clinicians move toward an accurate diagnosis. The process has two essential steps: generating a differential diagnosis. Before running tests, we list all possible diagnoses and estimate how likely each one is. Decision support systems can assist here by ranking these possibilities based on patient data. Incorporating diagnostic tests. Test results refine those probabilities, ruling out some options and strengthening support for others so that the most likely diagnosis comes out on top, emerges. And we'll also explore two important variations. So we'll explore screening, so using diagnostic tests on healthy populations to detect diseases early and change its course. We'll look at clinical prediction rules where multiple pieces of information, including test results, are combined to estimate the likelihood of disease. Ultimately, evidence based medicine helps us evaluate both accuracy and the effectiveness of diagnostic tools, ensuring they genuinely improve patient care. Certainty, uncertainty, and probability in diagnosis. When we talk about diagnosis, we often focus on how certain or uncertain we are about it. In medicine, this certainty is usually expressed as a probability, and probabilities are measured on a scale from 0 to 1. So if you prefer 0% to 100%, you can use that as well. So, for example, flip a fair coin, the chance of getting heads is zero point 0.5 or 50%. Likewise, the chance of tails is also zero point 0.5 or 50%. Another way to describe this is with odds. Odds are the ratio of the chance that something happens to the chance that it doesn't. For a coin toss, the odds of getting heads are 1 to 1 or even odds. If we roll a single six-sided die, the probability of getting any specific number is 1 over 6, or 1 6, which is about 16.7%. And the odds would be 1 to 5, one chance of success versus five chances of not getting that number. This way of thinking helps us translate diagnostic uncertainty into numbers, which then guide better decision making in clinical practice. Probability and Bayes' theorem in diagnosis. So another principle of probability is the total of all probabilities must equal 1. With a coin flip, for example, the probability of heads is 0.5 and the probability of tails is 0.5. Together, they add up to 1. Now, in medical diagnosis, things get more interesting. When we want to calculate the probability of a disease using information from a diagnostic test, we turn to Bayes' theorem. Bayes' theorem is a statistical formula that helps us move from pretest probability and our best estimate of how likely a disease is before testing to a post-test probability, also called the posterior probability. That's the updated likelihood of diseases after we factor in the test results. And this principle shows us why knowing the pretest probability is also important. So if we don't know how likely the disease was to begin with, we can't accurately interpret what the test results really means. And so while Bayes' theorem has many uses outside of medicine, in healthcare, it's one of the foundations of evidence-based diagnostic reasoning. Diagnostic thresholds. In diagnosis, we also work with the idea of thresholds. Imagine a scale running from 0 to 100% probability that a patient has a disease. On this scale, there are two important cutoff points: the test threshold and the treatment threshold. Below the test threshold, the disease seems so unlikely or so insignificant that we don't bother testing. Once we pass the test threshold, the probability is high enough that it makes sense to order a diagnostic test. As a result, as the results come in and our uncertainty increases, we may eventually cross the treatment threshold, the point where we're confident enough to begin treatment, even if the probability isn't 100%. The location of these thresholds depends on the risk and benefits of treatment. If a treatment is safe and highly beneficial, the treatment threshold can be set lower. But if treatment carries significant risk or side effects, the threshold will be higher. We'll want more diagnostic certainty before acting. This framework reminds us that diagnosis isn't just about numbers, it's about balancing uncertainty with clinical judgment, patient safety, and the consequences of our decisions. Screening and its role in healthcare. So, screening is closely related to diagnosis, but it isn't quite the same thing. Screening is about identifying unrecognized diseases, finding health problems early before symptoms appear. And the goal is to intervene at an early stage. Sometimes this means primary prevention, stopping a disease or its complications from ever developing. Other times it means secondary prevention, catching a disease that's already present and preventing it from progressing or causing harm. So, what makes a good screening test? Low cost, because screening is usually applied to large populations. Effective intervention. The tests must lead to a treatment or strategy that actually improves outcomes. Ideally, this is proven in randomized controlled trials. Highly sensitivity or high sensitivity. And so we want to catch as many true cases as possible and avoid false negatives. But sensitivity isn't the whole story. A positive screening result is usually followed by a second test with high specificity to rule out false positives and confirm the diagnosis. So, in short, screening helps us act earlier, but its real value lies in linking early detection to meaningful, effective care. Screening and engineering inspection. So let's talk about screening in medicine first. This has a lot in common with inspection and engineering. Both are about finding hidden problems before they become serious failures. In engineering, inspections are done on, say, bridges, aircraft, machines, is probably what we normally think of. And the goal is to detect, say, cracks or wear or weaknesses early on so that they can be repaired before leading to breakdowns or accidents or worse, catastrophes. In healthcare, screening is applied to people who seem healthy. The aim is to uncover hidden disease like high blood pressure, diabetes, or cancer before symptoms appear so treatment can begin early. Both processes share key features. Applied broadly, things like bridges, airplanes, or large populations of patients. If we're looking at low costs and practicality, inspections and screening, they need to be efficient because they're done at such a large scale. And then follow-up testing. So if an inspection or screening finds something suspicious, more precise and specific tests are performed to confirm whether it's truly a problem. So if we focus on prevention, the ultimate goal is to prevent catastrophic outcomes, whether that's a collapsed bridge or advanced disease. So screening in medicine is like a preventive maintenance check in engineering. Excuse me, an early warning system that's designed to catch problems um, is useful if you get them while they're still manageable before they get out of control. Screening tests, the double-edged sword. So Americans love screening tests, is what I hear. Even when the evidence for some of these tests is limited, or when doctors caution that a test may not be very accurate or that there may not be an effective treatment, people are still willing to go ahead with testing. But there's a problem. Screening tests can come with a high cost, especially when it comes to false positives. There was a landmark 2004 study that looked at screening for prostate, lung, colorectal, and ovarian cancers. It found that 43% of people who were screened had at least one false positive test result, and those false positives weren't harmless. They led to extra medical spending of more than 1,000 per person in the following year, though. In addition to the cost, screening has also sparked public controversy. So in 2009, a review of the evidence questioned the value of mammography in women under 50. The concern was that for this group, the harms of screening, such as overdiagnosis and unnecessary treatment, might outweigh the benefits. And following in 2011, the same debate arose over prostate cancer screening with the PSA test. The key question here was, did the risk of excess surgery and its complications in men with cancers that would never spread outweigh the potential life saving benefits in those with more aggressive disease? And these debates highlight the central tension of screening. On one hand, early detection can save lives. On the other, screening can cause harm if the benefits don't clearly outweigh the risk. Clinical prediction rules. So we'll finish this lecture with a look at clinical prediction rules. You may have seen these in medical literature, and the idea is simple. Instead of relying on just one test, prediction rules combine multiple sources of information: blood tests, imaging, clinical findings, signs and symptoms, all of this to estimate the likelihood of a diagnosis. The strength of a prediction rule depends on how well it's developed and validated. The best ones are created in one patient population and then confirmed in an independent group to make sure they actually work. So if we take a deeper look, let's look at an example. So we can look at deep vein thrombosis or DVTs. DVT is a blood clot in the deep veins of the leg. The danger, of course, is that part of the clot can break off and travel to the lungs, causing pulmonary embolism, which can be fatal. The problem is that no single test is both highly sensitive and highly specific for DVT. That's where clinical prediction rules help. We have something called the Wells score, developed by Wells and colleagues, and it has a high sensitivity but only moderate specificity. In practice, that means it's better at ruling out DVT than confirming it. And with a potentially deadly condition like DVT, being confident you've ruled it out may be more important than ruling it in. So, prediction rules are also applied in other areas, like, for example, a study on coronary artery disease, CAD, found that many newer risk markers added little value beyond the basics. So, cholesterol, family, history, high blood pressure, and diabetes. Another study compared popular cardiovascular risk prediction models and found only limited evidence and inconsistent results. In short, clinical prediction rules are a tool to synthesize multiple pieces of information. They help guide diagnosis, assess risk, and test whether new markers of disease actually add value. So this concludes part 4 of our series on evidence-based medicine, evidence-based practice. And we explored one of the most common questions in medicine, diagnosis. We saw how diagnosis blends logical reasoning and pattern recognition and how the process unfolds in two essential steps. I have to add something here is you do this, everyone does this every day when they're doing certain decisions in their life, big decisions in your life. We just don't call it this. So you're familiar with these processes. But sticking to this topic and applying it just to this lecture, let's continue with generating a differential diagnosis. And this is where you list possible conditions and estimating their likelihood. Incorporating new information from diagnostic tests when you get it. You use this to refine those probabilities and arrive at the most likely diagnosis. And we also discussed the role of probability and Bayes' theorem, the concept of thresholds for testing and treatment, the strengths and pitfalls of screening tests, and the value of clinical prediction rules in combining multiple sources of evidence. Together, these tools they can illustrate how evidence-based medicine helps clinicians navigate uncertainty. It helps them make informed choices and ultimately improves the patient care, which is why we are all here and probably why you're listening to these recordings. And again, with that said, I want to thank you very much for your time, and I'll see you in the next part.